Good afternoon. This is Dr. Jeremy Cutsforth-Gregory at Mayo Clinic in Rochester, Minnesota. I'm excited to be here during Leak Week with the Spinal CSF Leak Foundation. We're going to do a Meet the Expert Q&A session. I hope you're all getting your questions ready. We will take about 30 or 40 minutes to do this. And I hope that as you get settled in, we can take just a couple minutes to talk about what the practice is here. This is the first Meet the Expert session for Mayo Clinic, so I'm excited to represent our team. We really do take a team approach. And you'll hear today and then see here just in a minute my colleague. This is Courtney Ross. She is a physician assistant in the neuroradiology division. So our folks who go through myelograms often get to meet Courtney. Come and say hi, Courtney.
Hello, everyone.
Good. Thanks so much. And while we do give people a few minutes to say hi, let me take just a couple minutes to talk about how our team works. We include neurologists like me, neurosurgeons, neuroradiologists, and anesthesiologists, really to try to provide a multidisciplinary approach to patients who have either suspected or confirmed spinal CSF leaks. We work together both in clinic and also on various research projects as we try to improve the care for people who deal with symptoms of spinal CSF leaks. I want to pay tribute to the founders of our CSF Dynamics clinic. It was two gentlemen, Dr. Bara Mokri, my late mentor, and Dr. David Peepgrass. And if folks have been to Mayo in the last several years, they probably met one or both of these fine folks. Dr. Mokri was really a master clinician, and he was one of the original people to describe the pachymeningeal enhancement or dural enhancement sign that indicates spontaneous intracranial hypotension. And Dr. Peepgrass is a surgeon who worked with Dr. Mokri for many years, advancing the practice, operating on patients. He has since transitioned just to a clinical practice and sees patients along with me and others with leaks and help get things taken care of. Without these two folks, we wouldn't have the team we have today that has now expanded quite a bit with folks like Courtney, a number of neuroradiologists who do diagnostic and treatment studies, and then the anesthesiologists who do some of our blood patches. It really is a team approach, and without the whole team, we certainly wouldn't be as successful as we are. In terms of research at the current time, we are working on several kind of visions or projects. And first is to see if there are any clinical features that folks like you all might experience that would help predict which type of leak you have. And then how does that lead us to the most efficient way to diagnose a leak? Looking at developing an algorithm to transition from suspected leak to symptom kind of classification, quantification, to the diagnostic tests and a treatment as quickly as possible, because I don't have to tell you that the symptoms here can be truly debilitating, and it would be helpful if we could educate ourselves and educate others on getting relief as quickly as possible. That's mostly what our focus is. As we get ready to answer your questions, please remember that this is really not the forum for personalized medical advice. Keep your questions fairly generalized so that everyone who's listening in and watching can get something out of the responses. With that in mind, Courtney, if you're ready, let's get started.
Okay, we have our first question from Linda. Linda says here, I've heard good and bad things about cisternagrams. What is their role in the evaluation of spinal CSF leaks?
So cisternography really is a bit of a controversy, although I'll tell you how we look at cisternagrams and when we find them helpful and when we don't. So first and foremost, I think we have to know, does a patient have a leak or not have a leak? And so many of you know MRI can show that, and I'm sure later we'll talk about the various ways MRI can be used. But in at least 20% of patients, MRI of the head will be normal, and yet they have symptoms that suggest a leak or go on later to be proven to have a leak in some other way. So we use cisternagram when we think someone has a leak, but MRI is normal, to try to, before we commit to all the radiation, the expense, the potential risk of a myelogram, we do a cisternagram. It involves a lumbar puncture, so putting a fine needle in the low of the back, injecting a contrast dye, and then watching that dye move up the spine and over the head. Now, cisternagrams are not good for finding where the leak actually is, but they can tell us if a patient has a leak, to give us that kind of knowledge about whether to keep pushing further and further, because sometimes it does take quite a bit of pushing in order to find a leak, but you want to know that it's worth doing all of that, putting the patient through all of those procedures. And so what we'll do, if the MRI is negative, we'll do a cisternagram, and if you watch that dye move up, we take pictures about an hour after the injection. You can see the spine, About 6 hours later, you can see the bottom of the head, and then at 24 hours later. And it really is that 24-hour picture that's critical. And if you see dye that only makes it partway up the head, never really is up over the top, that patient has a leak in the spine. I don't know where, may not know where it is, but I know it's there, and I'm willing to do as many myelograms or different types of myelograms as it takes to find the leak. If, on the other hand, MRI was normal and the cisternagram shows complete contrast up and over the head, just as bright as lower down at 24 hours, it's pretty unlikely that this patient's symptoms are actually due to leak, and I want to think about alternative causes. That's how we use cisternagrams.
All right, excellent. Our next question is from Gabriella. How long does it take for the CSF fluid that has leaked out to get reabsorbed, and where does it get reabsorbed?
So in terms of the rate of spinal fluid production and loss and how those things interact with each other. We know a bit about this, but not everything yet. We also know that patients can have leaks that are fast and leaks that are slow. And it's actually critical in terms of figuring out what type of myelogram is going to find that leak and how we might treat it. So some patients have leaks that are so fast that as the fluid is leaked out into the spine, it builds up into a fluid pocket. Some people call them a cyst. Sometimes it's called a ventral epidural fluid collection. It goes by a variety of names, but that leak is faster than the body can absorb it, and we'll do a dynamic myelogram. Some patients have very slow leaks, and we haven't yet figured out which symptoms predict which type of leak, because we've seen patients who have severe headaches with slow leaks, or severe headaches with fast leaks, or no headaches with slow leaks, or no headaches with fast leaks. So we're still missing some of the clinical detail as to how to predict which type of leak a patient has. So we'll use MRI of the spine to try to tell that apart. Now the other part of the question, how fast does the body reproduce fluid? Turns out the body actually is continuously making spinal fluid. This occurs up in the brain, and it makes about 3 times the total volume every day. That is to say that you could completely replace your spinal fluid 3 times a day, unless it's leaking out, and then it can't really keep up. What other questions do we have, Courtney?
We have Krista that asks, what is dural sensitivity, and how can someone with this diagnosis be treated?
I think there's probably a couple different things meant by dural sensitivity. First, in terms of anatomy. So the pain receptors for the brain aren't in the brain itself, they're actually in the dura. So the dura is what feels headache. The brain doesn't. The brain perceives it and tells us that there's a headache, but the dura is what feels it. And so I think for some people, dural sensitivity means that where the pain receptors are has been either disrupted by a surgery or being stretched by the brain sag that a spinal fluid leak can cause, and that sensitizes it to more pain. You know, we, not just in spinal fluid leaks, but in other headache disorders, chronic pain felt by the dura can sensitize it to other chronic pain or more chronic pain down the road. And for some people, I think that's what they call dural sensitivity. The fact that you had a leak before, whether it's fixed or not, you can still have pain, or you had migraines before and they became chronic migraines. I think dural sensitivity probably contributes to all that. And in the spine, I'm not sure what dural sensitivity would refer to, so I'd have to know a little bit more. Hopefully that answered your question.
All right, we have another question from Emily. Emily's question is, after having digital subtraction myelograms and we are still unable to locate a leak, what other options are available to locate a leak?
So there are a number of types of myelograms, and maybe talking about the different types of myelograms would be helpful. Digital subtraction myelogram, or DSM, is one of them. But we also will do CT myelograms, MRI myelograms, positive pressure myelograms, dynamic myelograms. You'll hear all these different terms. In general, myelogram means you inject dye into the spine and then take pictures of some sort to find them. So a CT myelogram means you put dye in and do a CT scan with thin slices up and down the spine. MRI myelogram means you do an MRI. In all the cases, though, you're trying to put dye where it belongs and watch it leak out into somewhere where it doesn't belong. Now, digital subtraction myelogram, both here and at other centers that specialize in finding and treating CSF leaks, has become one of the most sensitive ways to find slow leaks. Because what you get is by doing the subtraction, you get a picture of this contrast dye in the dura and you get to subtract out a lot of the background noise or background image. Before saying whether a DSM is the right study for someone or not, or why it hasn't found the leak, you have to make sure the patient doesn't actually have a fast leak. It's also possible that patients have such leaks that are either so slow or intermittent that doing the DSM at a time when they don't have the most severe symptoms, or doing a DSM in a particular position, might not accentuate the leak. So there's so far no agreed upon best way to go next, but one thing that we would often consider if a DSM was negative would be to inject extra saline into the spinal fluid as part of the myelogram to kind of increase the pressure. I liken this to the car tire. If you get a nail hole in the car tire and you pull the nail out, you hear that hissing, and it's easy to find the hole. If instead it's just got a very slow crack in the rubber, you may not find it until you pump the tire up harder, and then the leak becomes more exaggerated and you can find it. So doing a positive pressure in combination with the digital subtraction myelogram might be a next step. If you've done multiple myelograms and you don't find the leak, what you've hopefully found are at least suspicious areas, and so then what we would tend to do would be multifocal targeted blood patches. We know blood patches can help either seal off the leaks or at least increase the pressure temporarily to help symptoms. And so if we have had a myelogram that hasn't shown us definitively where the leak is, then we'll do blood patching. And that's probably what I would do if we have had multiple DSMs. Blood patch for a number of months until some time has gone by or symptoms have evolved, and consider doing another myelogram. Courtney, what other questions do we have?
We have a question from Shayna, who asks, can we discuss CSF venous fistulas? It seems like they're being diagnosed more often than they were even a year ago.
That's true, for sure, and that's true here at Mayo Clinic Rochester, and I think it's true at other centers. As I talk to colleagues both at Duke and at Cedars-Sinai or at Stanford, which are probably the big centers in the U.S. right now, but absolutely, CSF venous fistulas are being diagnosed more often. And it's for two reasons. We know they exist, and we have better ways to look for them. Right, so if we had a time machine go back to 2013, the CSF venous fistula never been recognized, never been reported. And if you don't know that something exists, it's hard to look for it. So when Dr. Shivink and team reported CSF venous fistulas as a thing, then we had to figure out how to find them. The digital subtraction myelogram really has been a way to start finding fistulas, and so as DSM has spread and we've gotten better at doing them, tweaking the technique, we've been able to find fistulas more often. I doubt it's that fistulas themselves are more common, it's that we're better at finding them.
Next question comes from Linda. What is the benefit of an MR myelogram?
So an MRI does give more detail than a CT scan, but what you lose is time resolution, right? Because an MRI takes quite a bit longer to actually acquire the images. So if you're doing a myelogram where you've injected dye into the spine and you're watching it to leak out, if it's a slow leak, MRI might give you the right time course. If it's a fast leak, we often need to do a dynamic CT myelogram where you're getting pictures even as the dye is injected. Now there are some centers, Mayo is not one of them, will do a test called an MR myelogram without actually injecting dye into the spinal fluid. In that case, it's really just an MRI using different mathematical techniques, or the magnet, which is what an MRI is, to try to isolate spinal fluid signal from surrounding tissue. It's always going to be an indirect approach, because until you actually put dye into fluid and watch that dye come out of the dural sac, what you're doing is implying that the fluid you're seeing is moving through a hole in the sac. So again, it's myelogram is used typically when you're injecting dye, but this MRI myelography could be one of two things: injecting the dye and getting high resolution but slow MRI pictures, or never injecting dye, just trying to use math to separate dye from surrounding tissue. And that can be a little difficult sometimes.
Next question comes from Cindy. Cindy asks, my doctor does not believe that I have a CSF leak because my headaches never go away, even when I lie down. Do headaches due to CSF spinal leaks have to be postural?
They do not. And I'm sure there are many people watching the video here who have experienced headaches that don't go away when they lie flat. Now, an important thing that we know is true is that the longer someone has a spinal fluid headache, the less likely it is to remain postural. Which is to say, it might have been postural, worse when they were upright, better when they were flat back at the beginning, but after several weeks or several months or several years, it became a headache that just lingered around all the time. So it could be that the chronicity makes it lose its postural nature. That doesn't mean it's not any longer due to spinal fluid leak. So I find it really important to not only ask people about their headaches now, but how do their headaches start? And if you're one who's experienced a headache or experienced a spinal fluid leak, you know that your headaches can be different on different days. With all that being said, there's often still at least some improvement that patients can get by lying flat. And so one test that costs nothing to do is to lie flat with the head hanging down over the table, kind of back like this, to see if after 5 minutes or 10 minutes, there can be some improvement. I wouldn't require that the headache go away completely to say that it could or couldn't be due to a spinal fluid leak, but I would look for some improvement as, again, an indirect piece to support the idea that the patient might have a spinal fluid leak. All right, well, it's been about 15 minutes, so I just want to take a chance to reintroduce. We're here at Mayo Clinic Rochester doing a Meet the Expert Q&A session with the Spinal CSF Leak Foundation. My name is Jeremy Cutsforth-Gregory. We'll continue to take your questions now. Thank you.
The next question is from Azea, and she asks, in your experience, how often do patients suffer from rebound intracranial hypertension after their leak has been sealed? And also, how long do you follow these patients?
This is another really good question. So if the primary problem was spontaneous intracranial hypotension, low pressure or really low volume, and we can come back to that distinction later, of low volume of spinal fluid in the head, and then you treat it, some people will have a rebound high pressure state. We don't yet have an agreed upon definition of what is RIH, rebound intracranial hypertension. Conceptually we know it's an increase in the pressure, but it might not actually be an elevation of pressure above the normal level, just an elevation above what this patient's brain was used to for so many weeks or months or years. So without knowing exactly what the diagnostic criteria are for RIH, it's hard to say how common it is. What I do is I ask patients, if you get a blood patch or you get surgery on your leak and your headaches change, I want to hear about it. I hope they just get better, but if instead they become headaches that are worse in the morning than at night, that prevent you from lying flat in bed, that suggests there has been an increase in the pressure. We like that because it means that the treatment worked, but in the meantime, if your headaches are worse, we may want to use a medicine to reduce the production of spinal fluid, to temporarily reduce CSF pressure. The medicine is acetazolamide or Diamox, most often. And what we'll do is start it, and I give patients kind of the flexibility to adjust the dose up until they get some relief in their symptoms. Most people, and including me, do not want to put another needle into the dural sac to create a hole to measure the pressure, which at present is the only way to measure the pressure. So it's unlikely we're going to use actual spinal fluid pressures to guide treatment here, and so it is going to be based on symptoms and in looking for any swelling in the back of the eye called papilledema. So I will, if patients are close, I'll try to bring them back into clinic and look in their eyes and see if there is or isn't any swelling. Otherwise, we based it strictly on symptoms. And I would say that in terms of the number of patients who have a treatment and then require treatment, who have a treatment for their leak and then require treatment for rebound intracranial hypertension, it's relatively small, probably less than 20% in our clinic. But the numbers vary based on who you ask, and if it's just defined as simply a change in headache pattern, and that's all that's required to meet criteria for RIH, then you might be having 50 or 60% of patients. I think this is definitely an area where we and others can collaborate and try to agree upon what is RIH, how should we treat it, for how long. For some patients it's a few days. For many patients it seems to be a few weeks, and occasionally it might be quite chronic, many months. I think it's, I'll say in my experience, I haven't yet seen a patient who's had rebound intracranial hypertension for years. In fact, a couple times when we've suspected that, kind of weaned off the medication, looked again, and it was more likely a recurrence of the spinal fluid leak. It just didn't take on the original symptoms. And so I think when RIH, or presumed RIH, is going on beyond 6 months or beyond 12 months for sure, it's always worth reevaluating to see for sure that the leak isn't itself what's come back.
Connie has another question for us. Tell us how you sort out patients who may have POTS versus SIH versus both.
Oh, good. Yeah, there's nothing simple about these disorders, right? So POTS is postural tachycardia syndrome. SIH is spontaneous intracranial hypotension, which is also the spontaneous spinal CSF leak, and some patients get both. I think, though, it's the minority of patients who have both. So the defining features of POTS are a difficulty being upright, where the upright posture, gravity basically, introduces either symptoms of cerebral hypoperfusion, so you feel like there's low blood flow to the head. That tends to cause lightheadedness, dizziness, ringing in the ears, tunneling of vision, occasionally fainting. And it's associated with a rise in heart rate. 30 beats per minute rise is kind of the cutoff between a normal rise in heart rate upon standing and excessive. So POTS has well-defined criteria and would have typically normal imaging. SIH, as we've talked about and as you know, is actual active leakage of spinal fluid out of the dura, which will cause symptoms when you're upright, most notably headache, but not only headache. Some patients will have palpitations or pounding heart when they stand up, but if you actually measure the heart rate, it's less common than the symptoms that we actually see the diagnostic change of heart rate, more than 30 beats per minute, that would make someone also have POTS. The way I approach it is this. Patient comes to clinic and they say, I feel worse when I'm upright than when I'm flat. Okay, what is it, the things that make you feel worse? Are they symptoms of headache? Are they symptoms of double vision? Are they symptoms of hearing changes that you can make better by lying flat? But they sound like they could be leak. I'll start with an MRI of the head. And if there's any sign that there might be abnormalities of brain sag or pachymeningeal enhancement, then we'll go down the leak pathway. If instead these patients have the POTS symptoms, the fast heart rate, not so much headache, but more lightheadedness, with or without a faint occasionally, and I measure the heart rate upon standing and it really is an excessive rise, then I'll look for causes of POTS, because there are recognized causes of that disorder as well. For a while, I was systematically taking every patient who came to our leak clinic and doing a formal tilt table test and trying to see just how common is POTS in this group of patients who are known to have leaks, and it was about 2 patients out of 50. Now, we haven't published those data, and we haven't actually looked at them in great detail yet, just waiting for time to do that. But it was a very small number of patients who definitely had leaks who also had POTS. And when I look at POTS patients, I think what we also need is probably a prospective study to systematically assess for leaks with an MRI and or a cisternagram to see how often that occurs. I think it's important to keep both diagnoses in mind, but they can be differentiated and they usually come separately.
Excellent. Our next question is from Taylor. Do you only treat leaks by blood patches at Mayo, or is there ability to treat via surgical means if needed?
Absolutely, and actually that question gets at the multidisciplinary nature of our clinic. We do the neurologist, the neurosurgeon, so we definitely do surgery, and we do patches, and we have both anesthesiologists to do the kind of low thoracic or lumbar blood patches. That's often if we don't know for sure yet where the leak is and want to just try a very safe, quick and easy patch. And then we have our radiologists who can do very detailed, sometimes multiple levels, sometimes needles in right along the nerve root, what we call transforaminal blood patching. We're lucky to be able to do all of that, including the surgery and the different types of patches.
Next question is from Lauren. Do you see a relationship between CSF leak and the development of dysautonomia? The specific small fiber neuropathy, what would be the cause of the development of this? This sounds like a question that gets at, again, that overlap of POTS, which is the most common autonomic disorder in the same age group of patients who tend to have leaks, which tends to be younger people, although it can be at any age. As far as developing a small fiber neuropathy, that should be a separate disorder because that's a peripheral nervous system problem, whereas the symptoms of a leak come from the central nervous system, from the brain stem. So in this case, it sounds like the coming together of 2 separate things. It would be hard to come up with a mechanism where a leak would cause a small fiber neuropathy. Definitely could get both, and a small fiber neuropathy could cause POTS. By the way, the manner in which someone with a leak might subsequently develop POTS is most often related to the deconditioning that the orthostatic headache and other symptoms force. So patients who have to spend a lot of time in bed or in a recumbent position because of the leak symptoms can secondarily develop POTS. So nailing down the timeline can also be helpful as we try to differentiate these. Right? Did a patient have headache first and then weeks later develop the POTS symptoms? I would be more suspicious that that's a secondary POTS. By the way, just kind of going back to that earlier question. Thank you. I hope you keep your questions coming. This has been a great session so far. Courtney's kind of scrolling through. We've got lots of them to feed, so we're just trying to find some unique ones that we haven't already addressed. Stick with us. I have another question from Lauren, actually. If trying to seal a slow intermittent leak, do you recommend lowering pressure with Diamox to reduce the pressure on the leak itself, and would that promote healing?
I think this is a good question that doesn't yet have a definite answer. The idea being, should we use a medicine like Diamox to reduce the pressure inside the dura, the actual spinal fluid pressure, so that it's not exerting as much force to reopen a leak if you're trying to patch it? We've done a number of things over the years, putting every patient on Diamox after a patch to see if that patch would be more likely to stick. It wasn't in our hands. Putting no patients on Diamox and letting them ride out the rebound symptoms. I think it's unnecessary to allow those hypertensive symptoms to last. In our hands, so far, the best approach seems to be treat the leak, ask for feedback from patients, and if you have a change in headache pattern that is at all suggestive of rebound intracranial hypertension, then treating.
Next question is from Lou. Is there a link between CSF leaks and perilymph fistulas?
I think perilymph fistulas, basically would imply, is there a fistula between the lymphatic system and the spinal fluid sac, as opposed to the vein and the spinal fluid sac, as in a CSF venous fistula. There have been reports of lymphatic CSF fistulas, pretty rare. The ones that come to mind have been kind of single case reports in the literature over the decades, where a patient may have had a different disorder that kind of contributed to an underlying lymphatic buildup. So there's probably increased pressure in the lymphatic system. But this is so rare that I really don't think we have a good full understanding. And it may be, a year or 2 or 3 down the road, we realize that using a different technique to find lymphatic connections to spinal fluid, we describe a new lymphatic CSF fistula as opposed to the CSF venous fistulas. And once you find something, then it's a lot easier to look for it again. So stay tuned.
All right, our next question is from Rose. Is it possible to fluctuate between high CSF pressure and low CSF pressure?
I think it is. I think the only way to know for sure would be to have a measuring device, say a bolt, measuring the intracranial pressure in the head, which is quite invasive and requires being in an ICU. But if you listen to patients and hear their stories, it really sounds like either throughout the day or from one week to the next, they can have symptoms that very much sound like low pressure, and later on, some symptoms that very much sound like high pressure. When that happens, I think fistula is what comes to my mind first, because fistulas seem to have a tendency to open and close or be more active. Also, if you measured lumbar puncture pressure, so opening pressure at the low part of the spine, in the past you had to have a low pressure to get a diagnosis of a low pressure headache. That has since been debunked, and in fact probably more than half of patients who definitely have CSF leaks have normal pressure. And I would say anecdotally, patients with fistulas almost always have normal pressure, and sometimes even at the high end of normal or slightly elevated. So even as their leak is ongoing, they can have normal or high normal spinal fluid pressures. Tells me it probably is possible to have both symptoms at the same time, and I've definitely encountered people who explain they have or seem to describe symptoms of both. For me, that means you look hard for a fistula.
All right, I've got another question from Lisa. Are you using Fibrin glue at Mayo with patching and or surgery? If so, have you seen a correlation between Fibrin use and more frequent severe intracranial hypertension?
Okay, so yes, we do use Fibrin. It's very case-by-case specific though. Fibrin is not particularly easy to work with, right? It's an epoxy. That means it comes in 2 tubes, and as soon as you start mixing them together, it starts to solidify. So you have to know right where you want to put the Fibrin and have a way to get it there. It doesn't spread as well as blood does. So often what we'll do is, if we have a high suspicion of a site as being the site of the leak, then our radiologist will often include Fibrin with the blood. But again, it depends on a case by case. If we really don't know where the leak is yet and we're doing a non-targeted patch, it would be rare that we would use Fibrin in that setting. The second half of the question was, have we found the use of Fibrin being more linked to rebound intracranial hypertension? And I would say we have not seen that at this point.
All right, next question. Connie asks, have you seen patients with rebound intracranial hypertension that ultimately required CSF shunting or stunting?
We have not. So stenting and shunting are ways to reduce intracranial hypertension. I've heard of those patients, but we have not had any here yet during my time. Again, I would have a high threshold, so I would walk slowly towards putting a shunt, which is a permanent and invasive intracranial device, into a patient with rebound intracranial hypertension. But if a patient had papilledema, the swelling on the back of the nerves, then you need to do something to lower the pressure so that the patient doesn't lose vision. So in those rare cases, papilledema would be a time where I would think about doing either a stent or a shunt. Stenting, by the way, is usually opening up a vein in the head, or a venous sinus, because one name for something isn't enough. In the head, we tend to call the veins venous sinuses. And if there's a narrowing there and a pressure difference from above the narrowing to below the narrowing, then opening that with a stent. That's a procedure we actually use quite commonly in patients with pseudotumor cerebri syndrome, or also called idiopathic intracranial hypertension. But we have not had to use it here yet in a patient with rebound intracranial hypertension from a leak. But I think it's important to keep that in mind.
All right, Ted here has a really good question. If a patient wanted to be evaluated at Mayo Clinic, how would they start that process?
Absolutely. And so this goes for any symptom, including things that could be related to spinal fluid leaks. You call our appointment office, and I'll post the appointment number through the Spinal CSF Leak Foundation website so that it'll give you a way to contact. We like to triage the review records ahead of time to make sure this is a person we're likely to be able to help, or who also help coordinate which tests we might need or might not need because they've already been done. And so I'll be able to put out there the Neurology Appointment Center office. It's actually available if you search on mayoclinic.org or mayoclinic.com. Both of those websites can get you there, but we'll make it a little easier for you by posting here after the video session is over.
Sandy asks, what does fibrin strands in your CSF indicate? Is this specific to thrombosis?
Fibrin strands in the CSF, it really depends where they are. If they're in the spine, it probably means there's been some sort of violation of the dura, either a surgery on the spine, or blood patching, or a needle through the spine multiple times. The more common feature there would actually be something called arachnoiditis, where the nerve roots get irritated. That can be quite painful and hard to treat. Fibrin stranding in the sinuses, the venous sinuses of the head. So this isn't in the spinal fluid, but in the veins or venous sinuses themselves, often means a prior thrombosis or prior clot. As far as fibrin strands in the spinal fluid space of the head, I haven't seen it. It doesn't mean it doesn't exist, but I'm not very familiar and I don't want to give you false information about those.
All right, our next question is from Jill. Is there a link between CSF leaks and empty sella?
Empty sella is a common finding on MRI scan of the head. What it refers to is there's a bowl called the sella turcica, which means Turkish saddle, and the pituitary gland sits in there. With spinal fluid leaks, we often see the pituitary get bigger. With high pressure in the head, we'll see empty sella, or the pituitary get squished down into the bottom of that bowl. And so if I see empty sella, I'm actually less likely to think a patient has a leak, and more likely to think increased pressure is the problem. We definitely will see the pituitary change in size and shape as patients have a leak that gets worse, or has a leak that gets treated. The pituitary will shrink. If they get all the way to empty sella, the leak is probably resolved and we might be dealing with high pressure. How are we doing, Courtney? Still getting plenty of questions?
We're still getting lots of questions to
Good.
sort through here.
Okay.
Another question from Sandy. Can sinus atresia cause CSF pressure problems? How can atresia be clinically different from stenosis?
So atresia generally refers to sinuses or some body structure that never developed fully, either during embryological development or during childhood as we grow. And so stenosis implies that there was something, then it got narrow, or that it's always had a focal narrowing. Atresia, it just never fully developed. Now, as far as clinically differentiating those, I don't think there would be a clinical way to do it, but imaging should help with that. All right, we're into our last few minutes. We should have time for a couple more questions, so please keep them coming in, but no, we'll probably just answer 2 or 3 more questions.
Okay, we've got a question from Sophia. How commonly reported is ocular migraine as a symptom of intracranial hypotension? Why does this happen?
Symptoms of migraine in general are quite common in patients with leaks, and I think this often leads to misdiagnosis. So if you've got light sensitivity or you've got the visual aura, the squiggly lights or the flickering lights in the vision, it sounds like a migraine, might even meet diagnostic criteria for migraine. That doesn't mean the patient can't have a leak. And the longer you have a headache, then it can become a chronic headache, and sensitizing the dura can lead to migraine, probably in some people, and the longer they have it, the more migrainous it gets. I think if someone didn't have headaches, develops a new headache with or without migraine kind of features, including ocular features, then I always think about new daily persistent headache. Does this patient have a leak that we could try to treat and then deal with whatever migraine kind of residual there might be afterwards? But if someone newly develops what seem like migraines, but they don't act like migraines, meaning they don't respond to medications for migraine, then it's important for us, I think, to keep an open mind on to other possibilities, including spinal fluid leaks.
We have another question from Natalie. Natalie asks, why do we have such severe back pain after blood patches? And is it from being still so long? And are we making ourselves stiff by doing this?
How about yes and other things? So as you know, if you've had a spinal fluid leak, you'll often either have neck pain or mid-back pain or low back pain. That, by the way, doesn't predict where the leak is. There's not much connection between where the pain is and where the leak is. But to treat the leak, we'll often do blood patching. And part of the patch procedure is putting in blood until someone feels that pressure, because we want to get as much blood in as possible. We do know that the more blood in a patch, the more likely it is to stick and to last and give relief. So we want to get as much blood in there as possible. Doing that, unfortunately, means inducing a brief pain, but usually it's brief. Now, some people, and it sounds like Natalie has had more prolonged back pain, and it probably then means it's a combination of the brief irritation that comes from putting the blood in, the stiffness that before the treatment the muscles developed, and then whatever happens if patients do strict bed rest after a patch to try to get it to stick, that can contribute to more stiffness and more pain. It's probably a number of things, even more than what I've just talked about, and it makes it even harder to treat and even harder to deal with, I understand. But it's probably all those things, and it doesn't mean we shouldn't continue to do blood patches, because at least for the mechanism of the leak, fixing the hole should be what our goal is.
We have a question from Andy. In Germany, they are having success diagnosing the source of leaks by using contrast agent intrathecalgadolinium. In the UK, I've been warned that this is dangerous and the long-term side effects are unknown. Do you concur, and would you have concerns using this to diagnose?
I think this is a great last question, because it'll take me a couple minutes to talk about it. It'll take up our time, but it's an important point. So gadolinium is MRI contrast dye, commonly used in the vein. It can be put in the spinal fluid, but it would be considered off-label. So sometimes some people call that experimental. There are risks because intrathecal, or into the CSF, gadolinium has been done. We know that in most cases it can be done safely, but it hasn't been done enough to know if there are going to be long-term side effects. We were doing intrathecal gadolinium and MRI myelograms up until actually just about last year. And it was both because of concern, we want to make sure we're not causing any problems for people down the road, and also because we were able to kind of ramp up our digital subtraction myelogram practice. We were using MRI myelograms to find slow leaks and fistulas, and now by doing the DSMs, we're finding slow leaks and fistulas more effectively. We've gotten away from intrathecal gadolinium. And Courtney will correct me if I'm wrong, but I don't think we've done one in at least 9 months and maybe longer, and don't have any plans to do more except in exceptional, really extraordinary circumstances.
I would agree with that.
Good. So I hope we don't find that there were effects from doing intrathecal gad down the road. As I've said, we mostly phased it out of the practice and by replacing it with other techniques that are actually working even better. But intrathecal gad has been used. It is off-label, and it's off-label in the United States, and that would vary from country to country. I know it's used some places and may still have a role, but we've been able to get away from it. So thank you so much. I appreciate all the questions. I know we couldn't get to all of them, and I apologize for that. This video will be stored and available on the Spinal CSF Leak Foundation. We'll continue to answer questions there as we're able. I hope we get to meet some of you here in our Spinal Leak Foundation, Leak Clinic, get to meet members of our team, including Courtney, including me, and the other folks. Thank you again.